Welcome to the Deep Dive. We're all about getting into complex topics and, well, making them clearer and more useful for you.
That's the plan.
Today we're looking at something really fundamental. Human connection. Not just generally, but specifically in nursing, where it's incredibly sensitive and vital.
We're talking about therapeutic communication, and
Yeah.
it's not just chatting, it's patient-centered, it's goal-directed, and it's really a science-based art form.
Exactly. An art form. So for this deep dive, we're leaning heavily on Varkarolis' foundations of psychiatric mental health nursing.
Right. Our goal here is to give you, our listeners, a really solid toolkit for those crucial patient interactions. We want to make the sometimes complex terminology feel practical.
Yeah, break it down. We'll hit on mental health assessment, the actual techniques of therapeutic communication interventions.
And we'll tie it all back to what you actually do as a nurse day to day, and also what you need to know for the NCLEX exams. That's key.
Absolutely key. And, why is this skill, this communication art, so incredibly important in nursing?
Well, fundamentally, it comes down to patient safety. It's kind of shocking, but some studies estimate that 80% of medical errors involve miscommunication somewhere along the line.
80%. That's huge.
It really is. And beyond just safety, getting good at therapeutic communication, it boosts patient satisfaction, helps improve recovery rates, makes patients more likely to stick to their treatment plans.
It's really about building that trust, isn't it? So you can genuinely understand what the patient needs, whether they're talking about pain or maybe something they're not even saying out loud.
Precisely. It's the blueprint for connection in care.
Okay, so let's unpack that blueprint. Where do we start? The basic communication process.
Yeah, let's start there. It's dynamic, it's interactive. It kicks off with a stimulus, basically. The patient has a need, maybe information, maybe comfort, maybe advice.
Okay, the need. Then what?
That need triggers a sender, often you, the nurse, to initiate contact. The sender then formulates a message.
And the message, that's not just the words, right? It's everything.
Exactly. Words, yes, but also all the nonverbal stuff, tone, posture, everything. Then that whole message travels through a channel.
How it's sent.
Yeah.
Like hearing it, seeing it, maybe even touch.
Right. Auditory, visual, tactile, even olfactory sometimes. Then the patient gets the message and interprets it.
And then they respond. That's the feedback part.
Yes, and this feedback loop is so critical. It's where the receiver shows they understood or maybe didn't, ensuring you're both on the same page.
So you might ask something like, did I get that right? Or tell me if I'm understanding this.
Exactly. Or even noticing their nonverbals like, I see you look away when we discuss college. Is something bothering you there? It confirms that shared understanding.
So what are the sort of guiding lights here? I know Peplau had some core principles.
Yeah, Pipla highlighted two main ones. First, clarity, making sure both people really work towards understanding the message accurately together.
Okay, clarity.
Yeah.
And the second,
Continuity. This is about connecting the dots, linking ideas, feelings, events together to build a coherent picture for the patient, making sense of things.
makes sense. But it sounds like this process can get easily, messed up. What throws it off?
Oh, lots of things. Let's talk personal factors first. Psychiatric disorders themselves have a huge impact.
How so?
Well, think about depression. It can really slow thinking, reduce how much someone communicates, anxiety, makes it hard to concentrate, to take things in.
And mania?
Mania can make someone jump all over the place, unable to focus. So having a coherent conversation becomes pretty challenging.
And it's not just diagnosed conditions, is it? There are other personal things, too.
Absolutely. Obvious ones like language barriers, even with interpreters, subtleties get lost. Cultural beliefs are huge, too. They shape everything from eye contact norms to who a patient feels comfortable receiving care from.
Right. And then there are cognitive factors.
Yeah, things like intellectual disabilities, neurocognitive disorders, even psychotic states. These can directly affect problem-solving, memory, language use, the basic tools of communication.
So that's the person. What about the place? The environment.
Big impact. Environmental factors. Think about a typical hospital setting. Background noise, maybe not enough privacy, uncomfortable seating.
Yeah, trying to have a deep conversation with alarms beeping and people walking by.
Exactly. Even in newer units designed to be calmer, these things can still be barriers.
Okay, and one more factor. Relationships.
Right, relationship factors. We talk about symmetrical relationships like friends, where power is pretty equal.
Okay.
But the nurse-patient relationship is usually complementary. There's an inherent difference in status, in power.
That makes sense. The nurse has knowledge authority.
Exactly. But what's important to remember or strive for is that this power difference should ideally lessen as the patient recovers, as they gain independence. Your communication style actually shifts with their progress.
That's a really interesting point. So let's shift from the structure to the dynamics. Verbal versus nonverbal.
Okay. Verbal communication is, simply put, the words we speak. They carry our beliefs, values, feelings, all that.
Straightforward enough. But the nonverbal, that's where it gets really interesting, right? It's not what you say.
But how you say it, exactly. Nonverbal communication. It's your tone, your appearance, posture, eye contact, gestures, even little things like sighing or fidgeting.
Can you paint a picture? Like, what might you see?
Sure. Imagine a patient maybe slumped down in a chair, head in their hands, one foot just tapping, tapping, tapping. They haven't said a word.
But they're communicating a lot. Distress, agitation, sadness.
Right. It's complex, and you're decoding it. We often look at the eyes and mouth, specifically. Eyes can show sadness, anger. The mouth often signals happiness.
And the key takeaway here is,
nonverbal cues are often a much better indicator of true feelings and attitudes than the words themselves. This is vital for nurses.
okay, so how do these two interact? Words and actions.
We talk about content, that's the verbal part, what's said, and process, that's the nonverbal behavior that either backs up the words or contradicts them.
So when they match, that's good.
That's congruent communication, healthy messages. Think of a student saying, "My grades matter," and then you see them buying books, studying hard. Content matches process.
Makes sense. So the opposite is?
Incongruent communication, when the verbal and nonverbal messages clash. That same student says grades are important, but they're skipping class, not studying.
Creates confusion, right?
Totally.
Yeah.
And as a nurse, your job isn't to call them out like liar. It's to reflect the conflict you see. You might say something like, "You sound worried about grades, but you also seem relaxed about studying." Can we talk about the pros and cons here? You open the door.
That leads into something trickier, doesn't it? Double bind messages.
Ah, yes. Double bind messages. Bateson and his colleagues describe these. It's when someone, usually in power, gives two or more contradictory messages. Often one message is nurturing, the other hurtful.
Can you give an example? They sound complex.
The classic one is the chronically ill mother talking to her daughter. She says, "Oh, honey, you go have fun tonight. Don't worry about me. I'll just stay here. I can always call 911 if something happens. You just go."
Okay, sounds nice on the surface.
But as she's saying it, she's looking down, slumped over, maybe lets her cane clatter to the floor. The process totally contradicts the content.
Got it. It's a trap.
Exactly. A no-win. If the daughter goes, she feels guilty, selfish. If she stays, the mother might say, "I told you to go." It's that kind of dynamic. Understanding this helps you see the patient's hidden distress.
Wow. Okay, so understanding all this.
Yeah.
This leads us to the actual tools, right? The techniques.
Yes, your essential toolkit. Therapeutic communication techniques, and these aren't just random pleasantries, they're scientifically grounded methods.
And the goal is?
To achieve health-related goals, basically. Improve problem-solving, help patients find new coping strategies, build healthier relationships.
Okay, let's get practical. What are some key techniques? Silence. That sounds counterintuitive.
Using silence can be incredibly powerful. It's not just dead air, it's purposeful. It gives the patient space to think, to reflect, maybe to surface deeper feelings.
But you have to use it carefully.
Oh, definitely. Don't overuse it. It can feel awkward, especially maybe with kids or patients whose thinking is slowed by depression or schizophrenia. It takes practice to use it well.
Okay. What else? Active listening.
Active listening. This is more than just hearing. It's fully concentrating, understanding, remembering, responding. Paying attention to everything, verbal and nonverbal.
So you become like a sounding board.
Exactly. You give undivided attention, helping them clarify their own thoughts, solve their own problems just by truly listening.
And how do you make sure you are understanding correctly?
That's where clarifying techniques come in. There are a few types. Paraphrasing is one.
Which is?
Restating the patient's main point in your own words, usually fewer words, like, "So it sounds like you're saying." It checks your understanding.
Okay. And restating, how's that different?
Restating uses the patient's exact key words. If they say, "My life is empty," you might gently repeat, "Your life has no meaning." But use this one sparingly. Too much, and you sound like a parrot.
Right, robotic. What about reflecting?
Reflecting is about mirroring back the emotional tone you're picking up. You sound like you faced a lot of disappointment. It helps them recognize their own feelings.
You can also turn questions back on them with reflecting.
Yes. If a patient asks, "What do you think I should do?" you might reflect it back. "What do you think would be best, Kelly?" It empowers them.
Okay. And exploring.
Exploring is just gently digging deeper into important topics. Tell me more about your relationship with your wife. Or, crucially, asking for specifics. Give me an example of when you felt that way. Examples cut through generalizations.
Let's talk about questions themselves. They're different kinds, right? Open-ended.
Open-ended questions, yeah. They encourage sharing broader answers. What's been the biggest challenge for you lately? Things like that. They open the door wide.
Versus closed-ended.
Closed-ended questions ask for specific, often yes or no or short answers. Are your medications helping? They're useful for getting needed facts, especially like during an initial assessment. But again, use them sparingly. Too many feel like an interrogation.
Got it. Any other types of questions?
Two more useful ones. Projective questions often use what if, like, what if you had 3 wishes? What would you wish for? They help people explore underlying thoughts or priorities.
Kind of gets them thinking outside the immediate problem.
Exactly. And then there's a really powerful one, the miracle question. It comes from solution-focused therapy.
How does that work?
You ask something like, suppose tonight while you were asleep, a miracle happened and the problem that brought you here was solved. What's the first thing you'd notice tomorrow morning that would tell you the miracle happened?
Wow. That really makes you picture a different future.
It does. It helps patients identify what a solved problem actually looks like for them and what they're motivated to work towards. It's great for goal setting.
Okay, so those are the tools to use. What about the things to definitely avoid? The non-therapeutic traps.
Right. Non-therapeutic communication techniques, these actively hinder the relationship. A big one is excessive questioning.
Like rapid-fire questions.
Yeah. Why'd you leave your wife? Were you angry? What did she do? Are you going back? It feels like an interrogation, shows lack of respect, and shuts people down fast.
So the alternative.
Much more open-ended. Tell me about what happened between you and your wife. Simple, inviting.
Okay. What else is non-therapeutic? Giving approval or disapproval. That seems tricky.
It is. Giving approval or disapproval, saying, "Great job telling John off," might seem supportive.
But
it puts you in the judge's seat. The patient might start doing things just to please you. It fosters dependency.
so instead of great job,
Focus on their experience. "I saw you spoke up to John yesterday. How did that feel for you?" It keeps the focus on them, encourages self-reflection.
and disapproval, like
Yeah.
you shouldn't cheat.
Also, non-therapeutic. It's judgmental. Better to explore consequences. Can you think of how cheating might negatively impact your goal of graduating? Let them connect the dots.
Makes sense.
Hmm.
What about giving advice? Isn't that what patients want sometimes?
They might ask for it, but giving advice is generally non-therapeutic for nurses in this context.
Why is that?
It undermines their ability to make their own decisions. It implies, best fosters dependency. Instead of, "You should leave him immediately," you ask.
What options do you see for yourself?
Exactly. Empower them to problem solve.
Okay. And the dreaded why questions.
Ah, yes. Asking why questions almost always comes across as critical, implies wrongdoing. Why did you stop your meds?
Makes the patient defensive immediately.
Instantly.
Yeah.
Better to phrase it neutrally. Tell me about what led up to stopping the medication. It invites explanation, not justification.
Any others to quickly mention?
Yeah, definitely avoid things like minimizing feelings, "Oh, it can't be that bad," giving false reassurance, "Everything will be fine," or abruptly changing the subject when things get uncomfortable. They all shut down communication.
That's a lot to keep in mind. And all of this happens within a context, right?
Yeah.
Especially culture.
Hugely important.
Hmm.
Cultural competence in communication. Nursing is diverse. Patients are diverse. You have to understand how culture shapes communication, both verbal and nonverbal.
Build that alliance and avoid, well, messing up.
Right. Avoid unintentional bias. And practically, always check English proficiency. Get professional interpreters when needed. Please don't rely on family members for complex or sensitive info.
What are some key areas where culture really impacts communication?
Communication style itself is huge. How emotions are expressed varies wildly. Some Hispanic cultures might be very expressive, emotionally open. Many Asian cultures might value a calmer facade, seeing open distress as poor form. Germans, Brits, often more stoic. You need to know the norms.
Misinterpreting stoicism as lack of feeling or expressiveness as melodrama. Easy mistakes to make.
Very easy. Then there's eye contact. Big variations here.
Well, so?
Direct eye contact can feel disrespectful in some Hispanic cultures when talking to authority, Or for Japanese or Native American individuals, in some Middle Eastern contexts, it might imply intimacy.
Whereas in other cultures,
Like German, Russian, French, British, African American cultures, sustained eye contact often signifies engagement, listening.
okay.
So it's definitely not universal. You have to assess.
Okay. And touch.
Touch, also very culturally dependent. Therapeutic touch can be warming, supportive for some maybe Hispanic, Italian, French, Russian cultures.
But for others.
It can feel invasive, intrusive, even aggressive. German, Swedish, British, Chinese cultures might be less comfortable. And critically, always know your facility's no-touch policies, especially with patients who might be vulnerable or have trauma histories.
Good point. And we all have our own filters, right?
Yes. Cultural filters. We all listen through our biases, our prejudices, our own life experiences. They shape what we notice, what we ignore.
So the key is self-awareness.
Absolutely. Acknowledge your own filters to minimize distortion, to genuinely try and understand someone different from you. It's lifelong work.
Okay, let's pivot slightly to the modern tools. Technology in communication.
Right. Information communication technologies. Telehealth is a major one, using tech for long-distance healthcare.
Big benefits there, especially for access.
Huge. Reaching rural areas, people who are chronically ill or homebound, underserved populations. You can do remote assessments, monitor vitals, have crucial telepsychiatry appointments for things like PTSD, depression.
But there are concerns, too.
Definitely. Big ones. Confidentiality, making sure patients give informed consent, proper documentation, keeping records secure, data integrity. It's powerful, but it comes with serious responsibilities.
And what about apps? Everyone uses apps now.
Mobile applications. Yeah, they're being adopted really fast as clinical tools.
Yeah.
SAM-HS, for example, has free ones. Suicide safe for providers, no bullying for parents and kids. Talk. They hear you for parents about underage drinking. Really useful resources.
But similar concerns as telehealth.
Pretty much. Privacy, confidentiality are paramount. Plus, we often lack solid data on how effective or safe many apps are. And then there's liability. It's an area that's still evolving, needs more research, clear ethical guidelines.
Okay, so bringing it all together, mastering the actual clinical interview and growing professionally.
Right, the clinical interview. Ideally, the patient drives the content, the direction. Your job as the nurse is using all these communication skills to truly understand.
How do you set that up for success? The preparation.
Few key things. Pace. Let the patient set it. Don't rush them. Setting. Needs to be safe, private, maybe a conference room, a quiet corner of the unit where you can still be seen by others for safety. If you're in their home, that provides amazing context.
On seating, does that really matter?
It does. Think about comfort and nonverbal cues. Sit at the same height, no towering over them. Arrange chairs at a 90 to a 120-degree angle. It feels less confrontational than face-to-face. Make sure you both have a clear path to the door. And avoid using a desk as a barrier between you.
Little things that make a big difference. How about starting the interview?
Introductions are crucial. Who are you? Why are you meeting? How long will it take? And what are the rules of confidentiality, including the exceptions like harm to self, others, abuse?
And always ask how they want to be addressed.
Always shows immediate respect. Then, to initiate, use those open-ended questions. Where would you like to start? Or tell me a bit about what's been going on. Invite them in.
And just to recap quickly, things not to do during the interview.
Right. The tactics to avoid. Don't argue. Don't give false reassurance. Don't interpret their behavior for them. You're acting this way because.
Yeah.
Don't probe sensitive areas before trust is built. Don't criticize other staff.
And the do's.
Stick to facts. Make observations. I notice you seem. Listen actively. Clarify anything unclear. Manage your own anxiety. And always, always keep the focus on the patient.
It sounds like your own behavior is just as important as your words.
It's the foundation. We call these attending behaviors. Things like eye contact, generally more when they speak, less when you speak, but always watching their cultural cues.
Body language.
Body language. Kinesics. Are you slumped and closed off or leaning in, relaxed, attentive? It sends a powerful message. Personal space, proxemics. Know the comfortable distances, intimate, personal, social, public, and respect them. Getting too close or staying too far away can both hinder connection.
And your voice.
Vocal quality, paralinguistics. Your loudness, pitch, rate, fluency. A soft, calm tone encourages sharing. A fast, high-pitched voice might signal your anxiety. Think about how emphasizing different words changes meaning I will see you tonight versus I will see you tonight. Your voice is a tool.
Wow. It really is an art and a science. How do nurses get better at this? Practice alone.
Practice is key, but clinical supervision and debriefing are crucial. Debriefing isn't just venting, it's a structured reflection. It helps you move from knowing what a technique is to knowing how to use it, and finally understanding why it works or didn't work in a specific situation.
And process recordings or simulations.
Yeah, process recordings used to be common, detailed written accounts of sessions to analyze communication. Now, videotape simulations are often used in education. You practice, then watch yourself back, maybe with feedback.
So you can see, okay, when the patient said X, my response was Y, which was maybe non-therapeutic.
Exactly. Like if a patient says, I wanted to kill myself, a non-therapeutic response is, oh, don't say that, you have so much to live for.
Which shuts them down.
Right. A therapeutic response, which you'd practice and analyze, might be reflecting the feeling and assessing risk. That sounds incredibly painful. Are you having thoughts of harming yourself now? It opens the door safely. Debriefing helps cement that learning.
So wrapping this all up, mastering therapeutic communication, it really feels like the absolute bedrock of good psychiatric mental health nursing.
It truly is. It's that blend, isn't it? Scientific knowledge meeting genuine empathy.
Definitely. So as a final thought for everyone listening,
Yeah.
maybe consider how these principles really listening. Being culturally aware, choosing words carefully, noticing nonverbals, how they might not just change your patient care.
But maybe even enrich your personal relationships too. And take a second to think about your own cultural filters. What biases or assumptions might you bring into conversations?
That self-reflection is key. Keep building these skills. You're not just building knowledge, you're building empathy, which is what makes a truly great mental health professional.
Well said.
Thank you for diving deep with us today on The Deep Dive.